Good afternoon. My name is Maurizio Taramasso, and I'm moderating this session together with Isabel. Thank you for joining us to this simulation-based symposium, which is going to be focusing on some specific complex situation that we encounter when we perform tricuspid TEER. The session will be divided in two parts. The first part will focus mostly on clip strategy, and then the second part will focus mostly on complex lead-associated TR situation. And in order to demonstrate this, we will use the LifeTech simulator and we will implant the Gen 5 TriClip system on that. Without further delay, I would like to start with the first case presentation. We will use some cases to then move on to replicate the same situation on the simulator.
Perfect, and Eating Hang is going to start. Please let's make this session as interactive as possible. If there are any questions from the audience, just stand up and I will throw the ball at you anytime.
Thank you very much for the introduction. I'm going to start us off to whet everyone's appetite with the first case. So this is a 75-year-old female with a background of torrential tricuspid regurgitation. You will see she also has severe degenerative mitral regurgitation with an A2 prolapse that we had already treated with an Pascal 2 ACE implants in December 2022. Atrial fibrillation, meningioma, she has a history of squint surgery and other non-cardiac comorbidities, but as you will see, she's quite petite, and so despite being 75, we didn't feel she was an ideal surgical candidate. She's had progressive symptoms of NYHA class 2 to 3 breathlessness following mitral TEER after an initial symptomatic improvement, and her TRI score is 4. Just to show you some of her representative images, and before that, just to mention, medically speaking, only tolerating low-dose diuretics, and biochemically has some liver dysfunction in keeping with the significant tricuspid regurgitation. On her transesophageal echo images, you can see there's certainly a broad jet of tricuspid regurgitation that spans predominantly centrally, but does extend quite a bit. And actually, her tricuspid valve morphology is quite interesting. Rather than the standard secondary functional tricuspid regurgitation that we see, she's actually got quite myxomatous leaflets with an element of prolapse and quite a complex coaptation defect that you can see on the transgastric views. Profiling her tricuspid valve from anterior to posterior, you will appreciate leaflet lengths are reasonable, but this isn't a valve that certainly would lend itself to TEER very readily in terms of the leaflet coaptation heights, the coaptation gap centrally. And so to have a little thought about how we would clip this valve.
So maybe just quick, based on the image that you have seen, I ask Francesco, how would you clip it?
I would go for replacement.
And what would be your strategy?
I think it's very hard to get a good result with this Barlow-like disease. Yeah, so I think also about a replacement in this case at the moment. Yes.
I mean, you mentioned it. What we need, it's a good result, and a good result is not a TR of 3 or reduce it from 5 to 3. Yeah. What we need is a mild, or not even moderate, but actually mild TR. So a very complex case, I'd agree. So maybe we would move on to the second case and see what Vlasis Niños has brought with him for the second case.
This is the second case, 73-year-old man with significant comorbidities. You can see AF, chronic renal failure, pro-BNP elevated, a lot of TR, some LV dysfunction, previous PCIs, elevated PA pressure, elevated RA pressure, and TRI score of 7 on maximum tolerated medical therapy. And you can see now the anatomy. There's certainly a lot of TR. And the RV looks okay. And this is profiling the valve from anterior to posterior. You can see now dilated annulus, some tenting of the leaflets. Coaptation is impaired. And this is the transgastric view. You can see a big gap and having color across the coaptation line. Also, you can appreciate that the tricuspid valve is multi-scalloped. There are 2 anterior leaflets and potentially 2 posterior leaflets. Septal leaflet is there. There was enough length. And the coaptation gap is throughout and the color is coming throughout. Simple.
Wow. Okay. I think we can agree on two very complex cases. So maybe, Erwin, what are your thoughts on the second case? RV function, more of like ventricular kind of case, maybe? What are your thoughts on what challenges might be?
Yes, it's a bit challenging, but I think there is still a large anterior leaflet, a large septal leaflet, so we can start with a clip on the septal and the anterior leaflet, try to decrease the size of the tricuspid annulus and move on to a second clip, but we should be successful.
Okay, so your theory is put 2 devices anteroseptally and then...
probably we can start with 2 devices anteroseptally and then we will see if we need a third one.
Okay, any comments? Yes.
Definitely, I would be aggressive, with pre-treatment of this patient, to try to reduce the coaptation gap. Yeah. Because, with that gap, I think that would be extremely challenging.
You mean prehabbing the patient, right?
Exactly.
Yeah.
And would RV dysfunction be an issue, in your opinion, treating this case?
Well, might be, but, for repair, I think that, it's better, it's better tolerated in those cases, no? But anyway, I think that if that coaptation gap persists, it's maybe not the best intervention, edge to edge. Maybe more replacement, I don't know. But challenging cases, definitely.
Yeah, Aaron, there you go.
But just to make it clear, the afterload mismatch when we do TEER is not an issue, so we don't fear the RV dysfunction, I think. If there is a RV dysfunction, the patient is maybe too sick. But for the management of the regurgitation, it's not that an issue.
Yeah. One thing that's positive about those 2 cases is that imaging quality is quite good. So I think this is also important for TEER. Any questions or from the audience? Any other opinions? Yeah, there you go. Now you have to throw the ball up there. This is now your job. 1, 2, 3. Oh my goodness. So maybe we could maybe I will take over. Francesco, you try next time. All right.
I would like to ask about the first case. How it was the tricuspid regurgitation when the patient underwent the TEER?
Oh, excuse me, could you...
The TEER 3 years before, how it was the tricuspid regurgitation back then?
Moderate to severe. The mitral was certainly the dominant lesion at the time, but time has passed.
Have you thought the possibility of a combined procedure?
Well, so
by eliminating the MR, you saw improvement in tricuspid regurgitation, or it got worse?
So brief answers to both questions. We sometimes, but rarely, consider combined procedures. Her mitral valve was also Barlow-esque and myxomatous. We had a good result from that. The TEER didn't regress, but remained moderate to severe, but there's been clear progression since. So from a staged approach in this respect, we felt it was reasonable rather than tackling both contemporaneously.
And a last question. With this torrential tricuspid regurgitation, I noticed furosemide only 20 milligrams.
So she's clinically euvolemic, and this comes into the wet and dry phenotypes of patients with torrential tricuspid regurgitation. She's petite. She doesn't tolerate higher doses, which we had tried, including an SGLT2 inhibitor.
Thank you very much.
Thank you. I think now we try to simulate a similar situation in the simulator. I would like to invite Francesco on the simulator.
Yeah, sorry, before we simulate, I am a bit confused. What do we want to learn here? So I have a question for the audience, first of all, because you said we can do it. What do we do? What do we do? So who is doing TriClip here? Who is doing tricuspid interventions? Don't be shy, even if you're done one. Okay, so who would go, let's take the second. The first probably is a bit less common. Second case, functional TR, it is probably ventricular, because we have seen tethering. The TR is broad. Who will go for 2 clips in the anteroseptal? Who would go for a clover-like anteroseptal and posteroseptal? So who is the only anteroseptal here? Who would vote for anteroseptal only? Who would go for both antero and posterior? So 50-50, I love it. Great. That's the confusion we have. And that's what I think we should. First of all, there is also a third group of people here that probably they don't know what we are talking about. Should we clarify? What do you think?
I think it's a good idea.
I think it's a good idea. No? So how do we get this here like this?
I think we all agree that the first clip is going to be anteroseptally placed.
So now you see my skills. We don't know the posterior, but usually this is a very common, let's say, posterior. Can be one or two. Anyhow, and we have seen, we focus on patient number 2. The patient number 1, probably you are obliged to go both leaflets because everything is bulging. In the secondary TR, one option, one option is, we said, Ervan, you told, very large coaptation gap, start in the commissure, bring leaflets together, and go zipping. Usually 2 clips. The other option would be a clover where you have 2 clips implanted, one anteroseptal, one posteroseptal. That is for the 2/3 of the audience who didn't raise hands.
Hand.
Maybe some of them, they don't know. Well, I would like to discuss with you. So what would be your choice, the second patient?
I mean,
this one or this one?
Yeah, to be fairly honest, I don't think there was a lot of jet also in the posterior region. I'm not so sure if we put only anteroseptally 2 devices, if the posterior region would really sufficiently be reduced. So
Yeah.
I would
You
rather.
can say whatever you want because nobody, it's only an idea.
I would say clover.
You're clever. What about you?
I would probably, just to say something different, I would start, of course, anteroseptally, as central as possible, if the gap allows me not to stay really close to the commissure. And then, depending on how the residual jet is, decided whether to put a second one parallel anteroseptally, which would be probably my favorite strategy, or rather go for clover technique.
Yeah, probably this is a smart idea because of the coaptation gap, which is a lot. So probably it's good to start anteroseptal to bring the gap forward. Anyhow, you know what I think is, in my mind, when we have this discussion, the red clips are easy. The green ones are difficult.
No.
The red clips are probably less effective. The green ones are more effective. And as usual, we need to balance efficacy and complexity. Paolo is without the microphone, but I introduced Paolo Romitelli. For those who don't know, Paolo Romitelli, a good friend of mine, he doesn't speak good English, so that's why we take the
Not
microphone
like
out.
Francesco.
Huh? Now, you want the microphone? You can. He speaks Roman accent like me. Anyhow, this is the G5. Who knows G5 already here? So again, 2/3 of the audience, either you have a stroke or they don't have. You can react. So, if you have never seen G5, do we have a camera for us? No. Somebody can take my hands. No. That is okay here to show this.
The hands of the operator.
There are no cameras here, whatever. So then you watch here. Watch. It's okay, we don't have a camera. See, we didn't think about the boom camera. Anyhow, G5, basically, no difference in the implant. Some differences in the delivery system. What is the main change? There is no more decision making. Everything is very structured and more, let's say, repeatable and learnable. Okay, the way we manage this delivery system is easier than in the past. So it's easier to maneuver. more reliable, some improvement in the quality of the CDS, and the final release of the clip is easier. Let's say overall is an improvement in the handling. The TriClip system is already in this simulator that you see here. This is the LifeTech simulator. In this room, we do a lot of simulations. We decided to use only this one because today we have a specific learning objective that I think we should share, is that we need to discuss the technicalities of going for anteroseptal only or posteroseptal. So what is behind this decision is actually the chordal distribution, or let's say leaflet distribution. But what is really important is what is below the leaflets. And echo will not show you. CT scan will not show you. So you will have to do it blindly, but at least in the simulator, we are able to describe what it is. So can we have now the LifeTech after you manage this? We don't need it anymore. No, it's okay. No, we will need. But can we show now this the screen from the LifeTech now?
Yeah.
Yes, great. So what we see in the LifeTech simulator, which is on that strange, it looks like a robotic. There is a heart which is pumped inside in the middle. Is a real heart. Which kind of animal is this? It's a pig. It's a large pig. It's a right heart of the pig which is pressurized, and we have cameras inside. And what you see, what you were seeing, can we have it again, the LifeTech, guys? Thank you. Not this camera, the other one. Great. So what you see on the left side is the tricuspid valve from the ventricle, a view that you will not get in your practice. So keep an eye on what we see, because that is what you need to remember once you watch on the picture on the right, which is somehow you see it. So first of all, we already, Romitelli already implanted one clip, which is, you see there on the right side, you see it very well. There is a clip between the septal and the anterior leaflet, and the clip has been implanted nicely in the middle of the leaflet, first of all.
So like this.
Yes.
Like the red clip. Paolo.
And why the center of the clip is important? Because we are in the chordal free zone, no? And you have to imagine there are chordae here. Look at below. You can see from in the left side picture, the clip is not touching any chorda. It's in a chordal free zone. Why this is important? Because now let's try to have a second clip. Can we go? I do it?
Yes, why not?
If I fail?
I will come. I will let you.
Okay, so what we do, we unlock the system, correct?
Sure.
Then we close and we open.
Raise the grippers first.
Yeah, there is no difference. What is the difference? I can raise afterwards.
Okay.
No? It's okay. Whatever. Raise the grippers. They're already raised. You're fooling me. They were already raised. See, this is the problem with them. Anyhow, we open the clip. I'm very nicely in front of the. Let me see. We also have echo, so that's great. On echo, we have the the Philips machine, the latest generation with NPR. And also we like to show NPR somehow. We will probably describe a little bit. But basically what we do when we implant the second clip in a zipping technique, we should align to the first clip, more or less like this. Correct? You can see the clip, the first clip there. Do you agree?
More or less, yes.
What do you mean more or less?
You are not perpendicular.
You would be more like this, huh?
Yeah.
You want to be more like this.
Yeah.
Yeah. They moved.
Remove the camera.
It's okay. I don't need this camera, guys. It's okay. Keep the other one. Thank you so much. So you think it's better like this, more or less? Okay?
Yes.
You agree? So we close the clip. And we maybe should be more lateral. What do you mean? What do you think? A bit more lateral, no?
Yes.
So we go a bit more lateral. So we have the head knob, which will bring us also a little bit more posterior. You agree?
Yes.
And now we are pretty nice. Let's go in. You agree?
Yes.
Thank you. We we open. You agree?
Yes.
You agree? Grippers are up. We didn't check grippers, but it's okay. And so what happens now? What is the challenge, obviously? We have to land in a chordal zone. That is a little bit the challenge of going only anteroseptal. You will have to implant some devices impinging on the chorda. So what we can do, we can go as close as possible. Well, as close as possible to the first one. And try to grab leaflets. Not easy. Let me unflex a bit so I will land a little bit on the other one. Okay, that is the second clip. Do you agree?
Yes.
I agree. Doable. What is the drawback, Maurizio, in your opinion? If we go here, I mean, we're pulling on cord. We can even close the, let's drop the grippers and close. Let's see what happens. Okay? You agree?
Yes.
No, I did a mistake. I didn't
know.
lock. It's okay. Whatever. So what I see in this simulator, again, it is very convincing for me that we are interacting with the cord. So the drawback of this technique, number one, you're only treating half of the annulus because the clip is both a coaptation device and an indirect annuloplasty device. So you only correct one side of the annulus. Second, you risk to create tension in this commissure. I don't know if we have a pointer. Do we have a pointer? No. But you can see, look at the screen on the right side, and you see how the postero-anterior indentation is spread open. That is the risk you are encountering when you do this technique, particularly when the more posterior you go, you get there. So for this reason, my friend, I think we should raise the grippers, invert, and pray. Because usually it's not always easy to disentangle, but we'll try. We'll try, and we are good. We are good boys. We are good boys, I tell you. We are good boys. Nice. Somehow jumping. Yeah, here we are. Why is not coming up? Okay. Now let's simulate the other option to go into the. Now look where is the target. So we can try to go there. If we want to go into the posterior anatomy, which is this one, you agree on the orientation more or less? More
Yes.
or less?
Yes.
Yes. His role is only to say yes. Yes? If we go there, if you look below the leaflets, you see the complexity of chordal distribution. How do we find actually the ideal landing zone for this? And again, this is an animal and there is a huge variability. We don't know in the human being where the cords of the posterior leaflet, the septal leaflet are, how many posterior leaflet segments are. There are so many complexities. But then we still can do it with some challenge. Let's see if we can make it happen. We can go here, open a clip, find the chordal free zone, which is this one, pull, drop grippers, and this will be And you see how nicely coaptation is better. The patient is happy, family is happy.
Very nice and very clear demonstration.
Yeah, absolutely. Thank you very much. So we're very interested to see how our operators in real life did their cases, and we will ask Yiling again to show us her case resolution with our slides.
After Francesco saying we should have put a valve in, we did not. We obviously went ahead with a TriClip procedure. We elected to go with a zipping strategy in this instance, just with the complexity of the anatomy. You can see just on the left-hand representative image, the leaflets may be myxomatous, but the septal leaflet is still relatively restricted. So we placed the first XTW between the anterior and the septal leaflets, not too commissurally, before we then lined up a second XTW just posterior to the first. And actually we're able to target a further XT just posterior to the first two implants. So we took torrential tricuspid regurgitation in this complex valve down to mild moderate. You can see the quantitative parameters there with the 3D vena contractor orifice area. There was also quite a reassuring reduction in the right atrial pressure with a V wave of 30 down to 20, a mean of 24 down to 16, and actually a mean tricuspid gradient of just 2, which we felt was actually a pretty decent outcome given the anatomy.
Great, congratulations. Now Vlasis is up for the resolution of the second case that we saw, the more functional ventricular TR that you brought. I'm very interested in how you did that one.
As discussed earlier, we brought the patient in for some prehab, but the patient was already taking high doses of furosemide, so that was a bit of a challenge. And we thought we'll do a Clover technique. So we started with an anteroseptal clip. You can see after the positioning, that was pretty easy. There was still residual tricuspid regurgitation. We just wanted to see what happens in the transgastric view. This is fairly commissural, the first clip, but it was the best we could do because the gap was huge. But with some prehab, with some PEEP and the antitrodelable position, this is the coaptation that we managed to achieve. So we thought with the second clip we'll go posteroseptal. And you can see the two transgastric views before and after we positioned the first clip. And this is the second clip going in the posteroseptal zone, the Clover technique that Francesco was alluding to. You can see the transgastric view. You can see good apposition of the posteroseptal leaflet there. But there was a fairly big gap in between the clips, and there was another middle scallop of the anterior leaflet. And we could see a lot of color coming from this area. So we thought we'll try with a third clip in between them. That was pretty risky. But, we had a good landing zone and a good vision, and we were able to grasp the posterior part of the anterior leaflet, the A2 and the septal leaflet. And this is the transgastric afterwards. You can see now 3 grasping areas, 2 anteriorly, 1 posteriorly, with a fairly good result. There was some residual TR, but that was acceptable. What was impressive is the response of the RA pressure. The V wave was really ventricularized, very high, and it was truncated afterwards. And you can see the 3 clips on the fluoro. And actually, this patient did very well, reduced gradually the doses of diuretics. This is follow-up at 16 months, a couple of days ago. And he's doing fine.
Thank you, very nice.
Great.
Before moving to the...
Then what is the conclusion of this session? Clover is better or not?
You said we don't know, but actually it's not completely true because Xavier just presented some cases this morning, some data.
Surprise.
So obviously we need more evidence, but we have some information now on what should be the better or at least the most durable strategy.
So thank you, Mauricio. And can you just put the slide? This is data from this morning, be right? So where you can see actually, a comparative, analysis of 511 patients. They're like patients with single clip, but these two groups, it means that 148 and 112 comparing Clover and zipping. What we are assessing, what we are studying here it's true that most of the times, the clover or the zipping were determined by the anatomy more than the overall strategy. But in an ideal world where we can choose between one and the other, we care about durability. So what we saw that with zipping, after 30 days and at 1 year, it seems that the durability of the TR reduction decreases a little bit compared with the clover. So this is something that we will need to confirm. But actually, from this data, clover seems the winning technique. Thank you.
Thank you.
Thank you very much. Alrighty, so with this evidence wrap up, we're going to part 2 now. And now I'm going to ask our case presenters, first of all, Philip Nicolai, who is showing us a case. And both of the next 2 cases are dealing with pacemaker leads or transvalvular leads, another very challenging anatomy. And first of all, we are going to see a very short presentation of the first cases, starting with Philip Nicolai.
Yeah, thank you so much. I want to show you a case of an 83-year-old male person with an ICD lead induced TR, not torrential but massive, and the patient underwent of an M-TEER with a good result, had an aortic root replacement, an aortic valve replacement, so really a patient on high operational risk. Yeah, you see here the lead inserted and the massive primary or lead-induced tricuspid regurgitation. We see the lead normally lies on the septal posterior side. Here it's exactly in the middle of the valve, yeah, so opposite of the anterior posterior commissure and connected with the septal leaflet. Yeah, and there is also the tricuspid regurgitation coming from exactly this side. So the PA pressure is a little bit high, TAPSE is a little bit reduced, our VPA coupling is 0.3, so this is not a good patient for a valve replacement. Euroscore is absolutely high, also the tri-score is absolutely high. And yeah, this is our decision pathway. I think there is something to discuss what we can do with these patients.
Maybe we can ask Vlasis, how would you approach this patient?
Is it working? Oh. This is a tough case because you have the lead in the middle of the valve and it's always difficult. If you opt for TEER, you could go with clips on either side and try to trap it. I always like to look at the chest x-ray and see if there's slack on the lead, and maybe you could get a steerable guide and mobilize it to the more posteroseptal area, if possible, and free the central zone so that you can put 2 clips there. But that's not always possible. So I think clipping still remains the first option, but it's a challenging case.
Yeah, I'd agree. Okay, so then we look at the second case, and I think Ewandol has also brought us a case where lead impingement maybe even does play a role. It's always even more tricky.
Thank you. So it's my pleasure to introduce you a lady that I like very much. No, not a lady actually, a guy. A guy has an amyloidosis, so complex patient treated with tafamidis and treated with medical treatments, and the patient is still extremely symptomatic, and as sometimes in patients with amyloidosis, we have a pacemaker that need to be implanted because of conduction disturbance. And then when we have an amyloidosis, we try to keep the normal contraction of the LV, so we put the lead in the septum to have a left bundle branch pacing, and unfortunately the patient becomes sicker, and as you can see we have this huge tricuspid regurgitation. This is a torrential tricuspid regurgitation. Up. Doesn't work.
I mean, these images are bad enough, but you probably brought some more. Ah, yeah,
okay,
there we go.
So we can move on to the TOE, and you see that the lead is moving, so there is no attachment between the lead and the leaflets, and the lead is right in the middle of the valve. And then the question is, should we treat this patient with a TEER, or should we try to extract the lead because this is an option. We have to discuss with the EPs and see if we have to extract the lead and put something else, and then be free to implant TEER. This is a question. So EP discussion or directly TEER, or do we have to discuss TMVR? This is another option that we can discuss.
Thank you very much. So maybe hand raise. Who would extract the lead in the audience? I see heads shaking, but I see no hands raised too. Okay. Well, not a lot. So I think extraction, not so much, right? Any other comments from the audience, opinions? How would you treat one of those two patients? All right, then Xavier, what's your opinion? Second one, second case.
The second one, it's difficult, and actually, like it shows a situation that it's getting more and more frequent. It's like this physiological stimulation that comes from the posterior, crosses to the anterior side and to the septal. So there is a lot of interference. And honestly, that's always, like a thing. I would say that, maybe extraction, but I don't think that it will work. So then, sometimes, an option, for those patients is jailing. Try just to keep, a clip, in each side of the lid and see what happens. But it's definitely are difficult cases.
I love this jailing concept. How often we have done these cases? Many now. How often you jail and you are effective in jailing? Almost never. No, come on, let's be honest. How often at the end you jail the most occasions it goes where it wants. We need also to be practical, guys. So first of all, lead extraction, overestimated, more damage than benefit. Don't do it, stop. Second, I think in leads, what we learned, we have another partner. So when treating tricuspid, now the EP becomes a partner. We need to talk more. It's a larger team. It was not before. Thanks to tricuspid, we speak to EPs a lot, and we plan together. We can say, okay, sometimes, for instance, they need to extract the lead, and there is TR, and we need to discuss when we enter in the process. Should we implant the clip first, extract the catheter, put the second catheter, or the opposite? Or these strategies have to be discussed. But the real point, and it's also what happens in real life, is that probably in most occasions the lead is a kind of a confusing element, and we should only look at the anatomy of the clip of the valve itself and behave like the lead was not there. This is the reality, in my practice at least. But I don't know if anyone has a different opinion. But there are many patients. Ervan, you have been writing papers on this, so you have that, I know.
Actually, I think I looked at the first case. Of course, I know the second case, but the first case was very interesting. If we can see the septal leaflet, the anterior part of the septal leaflet was extremely restrictive, so it's very challenging. So we have to be very careful and look at the valves very carefully and see maybe there is just a small interaction between the lead and the leaflet, but if there is a restriction in the septal leaflet motion, it could be extremely challenging.
So probably just to maybe the audience again, I would like to share, the PCR tricuspid focus group has been one of the groups who have been discussing this, and we ended up in a classification, which is now very important to understand. Having a lead doesn't mean that the lead is responsible for TR. So I think the first case probably is a lead-induced TR, which is the lead is inducing because there is an interaction. The second is a lead-associated TR. There is a lead, but the lead is not mechanically involved in TR. Maybe there is some dysynchrony. This could be still reason for TR, but I think that is a key element where in the second case it's clear. We just behave on the leaflets like the lead is not there. In the first case, you might be creative and try to jade because the TR comes exactly at the contact. So I think that is important to realize. Okay.
maybe another question, maybe for Philip. Do you think there is any difference between ICD lead and pacemaker lead?
Absolutely not. No, there's absolutely not. But I can I say also the lead, it's extraction. If the lead is inserted more than half a year, it is connected with the leaflets, and this is not a good way. So we have also some bloody noses with that. Yeah, that the TR is not better afterwards. Yeah.
All right. So I think we should go to the simulator, or not? We should go to the simulator, but. Francesco and Xavier, let's go.
Yeah, well, now it's a challenge. I don't know if Francesco with me now, I think. Okay,
yeah, right, there he is.
So do you have
the pencil?
The pencil of the smart screen. It's here, the pencil of the smart screen. So basically, can we see the anatomy? Can we just put the screen there? Okay. Can we show? In the big screen. Okay, so here, as Francesco said, here it's a unique model where we can see, the tricuspid valve with a pacemaker lead there in the posterior. So I will, try just to do the same drawing. Okay, it would be more or less. Okay. No, this is not, sorry. It's just...
So 1 point to Francesco.
Yeah, like this. Okay, so where do we have the lead here? So more or less, it's here. So where it should be in general, correct me if I'm wrong,
Yeah.
should be like here in the, because this is posterior, this is septal, this is anterior because the aorta is here, okay? So usually it's here. And the fact that we're having TR, so sometimes if the lead is here, it's completely regardless. So it's not induced by the pacemaker. So you can have a jet, and then you will do your zipping or your Clover thing, regardless of this. But sometimes, especially like in the first case, so we have something, and like in the simulator, something here that it looks that it's interfering with the septal, and sometimes like with the posterior leaflet, or the third case that it's kind of in the middle that we don't know. So when I was just talking about like a standard, like that would be the standard zipping, that would be the Clover. When I was just like talking about jailing, it means that you can jail. Sometimes you cannot do it, but jailing you can jail it. In the commissure, because you're limiting the movement of the lead, or in very like few cases you can also jail it among clips, so the interaction is going to be less. This is extremely difficult. This is not happening, but this has been described and has been used sometimes. So let's go back to the model.
But I want to warn the audience. I mean, you can also damage the lead by doing this maneuver. You are scratching on the lead, so. We have been trying a lot to do this, but there are some challenges there.
So I will do what you tell me. So what do you want me to do here?
First of all, I want to show the audience the MPR. Maybe everyone, you know how to activate this. But if you look at the MPR that I managed to organize, we can see the lead very well. We have been aligning the MPR arrows to the lead itself, which shows very nicely how the lead in this particular animal model is behaving. Do you think it is impacting on TR in this particular case, Urban? Maybe you need the mic. He's here. You have a mic here.
Here.
So clearly we see that this is an associated TR with the lead crossing the valve, but there is no interaction between the lead and the leaflet, or a small interaction, but we still see that the septal leaflet is moving, so I think there is no clear interaction.
Okay. So I will change now the MPR to follow the procedure. So we align now to the device, not to the.
So what would you do? In this case, we have this anatomy. So what would you do? What would you try? Where would you put the clip?
As it has been said previously, we have to start with the septal and the anterior leaflet. First clip, and then we can decide if we We will not move the lead. We agree that we will not try to move the lead.
And this is a very important question. So we're considering here that it's like a TR in use, okay, by the pacemaker. So would you still put it anteroseptal, the first one?
Yes, always.
Always, even though there's no functional component.
We care about the anatomy, so we start with the septal and the anterior leaflet. That's it. I think it is a rule. I don't know if you agree.
Well, I don't know because in this specific case, and if I assume that it's MTR induced, I would probably go this position. I will try to limit, and go, just to the, to the place where the problem is. So, but this is open. I don't know who would treat more, anteroseptal. Raise your hands. In this, and who would treat more like posteroseptal. So it's anteroseptal more. Just winning.
So I would start anyhow anteroseptal because I am sure that this is only associated. First of all, second, because if you start posteroseptal, you will have a shadowing, will be a problem for any other clip. So if you start when you do multiple implants, you always start the most anterior one to avoid shadowing in a transgastric view. So you need to start anteroseptal first.
And what do you think about, as you already mentioned, the risk of getting, just damage, getting trapped, the pacemaker leak and the grippers? This is real or never happens?
Well, to grab you can grab. Yeah,
it can happen, but the thing is, you have the fluoroscopy and you see it perfectly. And if you bring your C-arm to an orthogonal situation and you see perfectly, you can shift the leaflet into the commissure.
Yeah,
I think that's.
He's trying not to do the case. Talk,
no,
blah, blah, blah. But you have to do it. Yeah,
you do it.
No, you do it.
Okay, so I'm gonna do what the majority wants. So instead of going here, so we will go. You know
what I did? I was helping you. I just put the MPR ready for you. If you go.
But you want me to go posteroseptal? You want me to go anteroseptal?
Anteroseptal, easier. No?
Okay, so then this is posteroseptal. It's like look at the diagram.
Paul is trying to help you.
Okay.
Go easy. Do the easy thing.
Just unflex, no? Yeah. And
so there is a way to guide this procedure is to use the MPR, the opposite of what most people do, that they align the MPR to the device. You align to the anatomy and to the target, and then the device has to go and somehow match. So for instance, I see, not bad, huh? But you are a bit not really in the quotation zone. You see on MPR you are not there. Also on the image you are not there. If you
okay, and let's unflex a little bit.
I have a question for you. Maybe should we open the clip more, or is it correct to have the clip that is not completely open?
That's a good technical question. In my practice, I always cross open. And the reason is that if you cross with the clip closed, you can get entangled in between chordae with the clip closed, which is a no-go. So I prefer to cross with open leaflets also because most of our practice is transgastric view. So you need to see, and you see clocking all the time you cross the leaflets. So I go with the open clip.
Oh, but I don't like it.
Many operators do the opposite way. They go with closed clip because they feel like safer. But that's, opinions. What do? You open, close.
I go inside with the open clip, and sometimes if I tangle in some chordae, I invert the clip a little bit and then go for the grasping situation.
Okay. Yeah? If you get entangled, sure.
If you have an entangled.
You go open or closed?
I go closed.
Closed.
Very shallow, and then I open, but I have my fluoroscope as a marker for rotation.
Rotation.
It works most of the times.
Yeah, there are different ways to do it, but I think it's safe. What it works is to be safe, not to be entangled.
Okay, so we did what you wanted. So we clipped the anterior and the septal. And I don't know what would happen to this patient if the TR persists. So now you would do the clover thing, no?
Yeah, the point is that you start there, and then obviously you can put the second one to jail the pacemaker, but always start anteroseptal first, otherwise you get in trouble for the next. Most of our procedures require transgastric. Why? Why? Let's see if anyone has the answer in the audience. Why is in the simulator? The why is in the simulator only. The answer is in the picture you see in the simulator. The only way to imagine, can we have a transgastric view on echo? Not from this one. Or maybe even from this one. Can we just not? You cannot have transgastric, correct? Anyhow, this is the picture you see bottom left from the echo is almost a transgastric view, almost, not really the same. In that picture, what you see, you don't see leaflets, you see chorde. So in transgastric, you can somehow reconstruct the three-dimensional, let's say the planimetry, not the three-dimensional, the planimetry of the valve. You can imagine where the chordae are, where the commissures are, where the leaflet, and when the chordal-free zones are, where the line of coaptations are, is the only image that really.
What do you think about that?
I love it.
But it's not always possible, no?
No. I mean, it is not always possible. Obviously, you show how you can jail, and actually you are abolishing that portion of the leaflet of the valve, which is a great situation. But in principle, the problem is that sometimes to obtain this effect, you are scratching on the lead. You are doing manipulations that can be difficult. What you mentioned before, somebody's using, you mentioned, you can use a agilis or other tricks to manipulate the position in order to have it very, very posterior. But but good. I did good. We treated 2 patients with no complications.
Thank you.
All right. So let's go again from simulation room to real life, and we'll see the case resolution first of Philip Nicolai.
So this is how we treat it. So we love the transgastric view. We have no experience with transesophageal view during grasping. We have no experience with 3D during the tricuspid intervention. We love the transgastric view. We love also to grasp in transgastric. And the thing is, we have a little problem here because we have a shadowing of the leaflet. So Francesco mentioned that if you go from posterior to anterior, then you have a shadowing. But now you see here the grasp loop, and it works. So the anterior leaflet is still on the clip arm, and also the septal leaflet is coming on the clip arm. And we can see it here. And this was the grasp. And the next grasp is that we want to jail the leaflet. We go septal posterior of the leaflet, of the lead. And I think we can do it also with this lead shadowing from a transgastric way. And this is the final result. Yeah, you see the ICD lead is jailed between the 2 clips, and also the final result after deployment of the clip is, I think, very good.
Congratulations.
Thank
Absolutely.
you.
Maybe while they change, just one quick question. Do you always do a pacemaker interrogation after these interventions, before and after, to check for pacemaker function?
Normally not. Normally not. If we have
we do actually in each patient that we treat with leads. But so far, no problem. So I think you're right in not doing it. So the second case resolution, Erwan, your case.
So yes, we discussed that it is important to discuss with the EPs, and you can see this paper that has been published. So I push you to read this paper. We don't have time to go into the details. And in this paper, you will see that there is an algorithm, and you will see that the patient we are dealing with is right here. So it means that the patient has an anatomy suitable for TEER, so we will do a TEER. And then it has been said we use the MPR a lot, so the MPR and the transgastric view. And as you can see, there is a finger just in front of the first clip, and we put the first clip close to the lead. So the lead is right in that position. We put the first clip in that location. We were quite successful with the septal leaflet, with the anterior leaflet, but as you can see, there is still some degree of regurgitation. And then we decided to move on to implant a second clip. And as you can see, after that, we have the lead that is in the commissure between the septal and the anterior leaflet. We have the first clip in that location. We have a second clip between the posterior leaflet and the septal leaflet. And the result at the end is perfect. As usual. No, not as usual, but no. It is a challenging case, but with 2 clips, we were able to succeed. And as you know now, thanks to Be Right, it is important, if we can do so, it is important to try to have a clip between the septal and the posterior leaflet on top of the clip that is between the septal and the anterior leaflet. Thank you.
Thank you very much. Perfect indeed. So this is us just wrapping up the session. Thanks a lot for the speakers who brought cases. Thanks a lot for the simulation. Thanks to all of you guys. It was great. We learned a lot about the advantages of Clover technique and also the challenges we have with leads and crossing the tricuspid valve. I really thank you, Mauricio. It was a great pleasure
thank you.
During the session. And thanks of all your attendance, and have a great further on Congress. Thanks.